So now we will discuss about the constipation. Constipation is reported in up to 70 to 100% of the patient requiring palliative care. Although hypercalcemia and other factors can cause constipation, it's most frequently predictable consequence of use of opioids for pain and dyspnea relief, and of the anticholinergic effects of tricyclic antidepressants as well, due to inactivity and poor diets common among the seriously ill patient. If the left untreated, constipation can cause substantial pain and vomiting, and also is associated with confusion and delirium. Whenever opioids and other medication known to cause constipation are used, preemptive treatment for constipation should be instituted. So these mainly hypercalcemia should be in our thought process, and opioids for pain and anticholinergic effects of tricyclic antidepressants. Assessing constipation can be difficult because people describe it differently. Four commonly used assessment scales are Bristol Stool Form Scale, Constipation Assessment Scale, Constipation Visual Analog Scale, and Eaton Scale Risk Assessment for the constipation. The Bowel Function Index can be used to quantify opioid-induced constipation. The physician should establish the patient's previous bowel habits as well as changes in subjective and objective manners such as bloating or decreased frequency. Abdominal or rectal examination should be performed to exclude impactation or an acute abdomen. Radiographic assessment beyond a simple flat plate of the abdomen, in case which obstruction is suspected, are rarely necessary. And any measure to address constipation during the end of life care should include interventions to re-establish comfortable bowel habits and to relieve pain or discomfort. Although physical activity, adequate hydration, and dietary treatment with fiber can be helpful, and each is limited in its effectiveness for most seriously ill patient, and fiber may exacerbate problems. In setting of dehydration or impaired motility, fiber is contraindicated. So the important point is fiber is contraindicated in presence of opioid use, and stimulant and oxidative laxatives, stool softeners, fluid enemas are the mainstay of the treatment. To prevent constipation from opioids and other medication, a combination of laxative and stool softener should be used. After several days of the treatment, a bowel movement has not occurred, rectal examination to remove imparted steel and place a suppository is necessary. For patients with impending bowel stool or gastric stasis, octreotide to reduce the secretions can be helpful, or in patients whom suspected mechanism is dysmotility, metoclopramide can be helpful. Then medications for management of constipation: stimulant laxatives, prune juice, senna, bisacodyl. Osmotic laxatives, these agents are not absorbed, they attract and retain water in GAT. And lactulose may cause flatulence and bloating. Magnesium hydroxide, lactulose works in the 1 day and magnesium products in 6 hours. Stool softeners, sodium docusate, calcium docosates, suppositories and enemas, biscodil, and sodium phosphate enema.